Ladies and gentlemen, we'll start our next session now, and the session will be on critical issues in child and maternal nutrition and will be presented by Dr. Mainul Haque, Research Fellow BIDS. And now I please request our session chair, Dr. Mushtaque Chowdhury, to please take his seat. And I would also like to request our distinguished panelists, Dr. Fahmida Tofail, Mr. Monirul and Dr. Mahfuza Rifat, to please take their seats. Thank you.
Good afternoon. My name is Mushtaque Chowdhury. I'm the Vice Chair of BRAC, and it's my real privilege to welcome you to this last session of today. I thank BIDS for inviting me to chair this session. It's real privilege. We have today a great panel who will be talking about nutrition in this country. And we start with a trigger presentation from Mainul Haque, Research Fellow at BIDS. Dr. Haque has a PhD from University of Iowa State University, and he's a microeconomist. Nutrition is his new interest. So,
thank you. Thanks for everyone for coming here. So as I was informally discussing with the distinguished panelists and the chair, that actually while working on a study with BBS and UNICEF, I just got some interest in nutrition, and I proposed this topic to be included in this critical conversation. So, and the study, I was working with our senior research fellow, Dr. Yunus, but he is present here, but I am presenting there. So many of the information that has been used in this study, in this presentation, is actually taken from that study. So let's start. Why nutrition is important? Nutrition is important for health because nutrition helps to build up a productive labor force, and productive labor force helps for economic development. It's so important that in the 19th and 20th centuries, the Nobel laureate economist Fagel, he find that about 1/3 of the increase in income in Great Britain can be attributed to the development in nutrition. We all know that Bangladesh has made significant progress during the last decades, and in terms of economic growth, in terms of human development, and the country has also made sufficient progress in nutrition. Like proportion of children under 5 who are stunted has come down from 55% in 1997 to 36% in 2014. Maternal malnutrition has also declined from 52% to 17% in 2014. So this is a remarkable progress compared to other similar countries. So the country, in terms of the economic development, in terms of economic growth, the country has recently been promoted to a lower middle income country. But if we compare the nutrition indicator with the other lower middle income countries, we see that the country's status is not yet that good. Compared to those countries where the malnutrition rate, which is reflected in the stunting rate, is 25.5%, we are like 11 percentage point lower. So what factors are actually contributing to this stunting thing, to undernutrition? is like poor child and maternal diet, poor health coverage during the pregnancy and the lactation period, poor hygiene environment, which includes the safe sanitation and safe water, and which are also related to poor empowerment of the women, low socioeconomic status, and food insecurity. So under nutrition, the cost is huge for the country. One study of the GOV and USAID 2013 that estimated that the cost is like $1 billion per year. So, which implies that if something is if the public money is invested in nutrition, the return will be higher. For every taka spent, the rate of return is 18 to 23 taka higher for each public money spent. This is an estimate from Copenhagen Consensus. So understanding the importance of nutrition for economic development, the government of Bangladesh has emphasized on reducing the impact of the malnutrition, undernutrition, and which is reflected in the 7 5-year plan and also the 4 health and population sector plan. So in being consistent with the SDG 2, which reflects more on hunger, nutrition, and sustainable agriculture, and SDG 5, which is related to the safe sanitation and water supply, the country has planned to reduce the proportion of stunting under 5 children from 36%, which is currently, to 25% by the end of the 7 5-year plan, and almost universal coverage for safe water and sanitation. So in this presentation, I will try to focus based on my secondary data review, secondary study review. I will try to focus on some of the critical issues that can be critical for the implementation of this plan. The first is the gap. There is huge gap in the accessibility and utilization of some essential public services which is related to nutrition. For example, the 36% accessibility, 36% of the lactating mothers in rural areas and 23% in urban areas do not have access to infant and young child feeding trained health workers within a reasonable walking distance. Similarly, 28% of the mothers in the fertility age range actually do not have access to ANC health facilities. So this is a huge gap is still there. But sometimes, even if you have access, it doesn't mean that it will be translated into utilization. If people don't utilize the service is there. What is the meaning of that? So we find that in our study with BBS and UNICEF, that 39% caregivers received promotion or counseling on complementary feeding practices, and only 47% women during their pregnancy that took the IFA supplements from the nearby health facilities. Besides this, there are huge regional and across division and urban-rural gap in the provision of this coverage. And in some districts, accessibility, like 40 to 50% of the people do not have accessibility to these basic services. The child feeding is very important. So the first 1,000 days, from inception to the first 2 years of the life, which is very important for the child growth, and there is a fetal origin hypothesis which is saying that the impact, the malnutrition during this period, it is like irreversible. So the nutrition is very important during this period, which includes proper breastfeeding, complementary feeding, and our study data shows that breastfeeding is not practiced in the optimal manner. For example, only 36% could initiate breastfeeding within the first hour after the birth. And almost 2/3 of the children who are supposed to be exclusively breastfed, they are actually introduced to other food. And for complementary feeding practices, we find that it's not only affordability, it's not that only the poor cannot have this service, is the socio-cultural norm is also very important. So it is recommended that children in the 6 to 23 months age group consume daily at least 4 of the following items, including like carbohydrate, protein, fat, vitamins, and minerals. But we find that only 45% women caregivers say that they know the correct time to start the complementary food, which is the 6 months of age. Only 20% children meet the minimum acceptable diet requirement, which satisfied adequate diversity and the meal frequency. Similar to the child nutrition, child feeding, the maternal nutrition is also very important and which has a profound direct impact for intrauterine and early child growth. So we find that pregnant and lactating women are not following the recommended increase in the dietary intake. though they are supposed to increase their food intake during the pregnancy or during the lactation period, we find that only 53% in urban areas and 42% in rural areas actually increase their dietary intake during the said period. It is recommended that PLWs consume daily at least 5 of the 9 food items, but we see that only 37% could meet that requirement. So why? One of the factors is the education. We find that education has a prominent role here. For example, compared to pregnant and lactating women with no schooling, mothers who have SSC or HSC level education, they are 18 percentage point more likely to change dietary pattern during their pregnancy and lactation, 20 percentage point more likely to ensure adequate food consumption, and 20 percentage points more likely to consume at least 5 items per day from the 9 food groups. And old age also matters. We find that mothers who are old age, like above 40 years, they are less likely to follow the diet pattern that is recommended. So again, like that maternal nutrition, the maternal health is also very important because there is a relationship between maternal health and the malnutrition of the child. So two important components of the maternal health are ANC service and the micronutrient supplementation. But the studies show that uptake of the antenatal care and micronutrients during pregnancy is very low. Like although 43% rural and 65% urban women in the fertility age range received antenatal care, more than 75% didn't take the service as frequently as it is recommended. They take the service for less than 4 times. And only 12% women received at least 100 iron and folic acid tablet during the pregnancy, and only though like more than 10% got the tablets, only 3 to 4% actually consumed all 100 tablets. And there are multiple reasons for this, like bad taste, like forgetting to take the supplement, long course. Next is the wash, which is also very important, which has implication for nutrition. Like wash is the good hygiene and the safe sanitation and hand washing is important because these improper practice in these 3 areas actually makes the children susceptible for infection. Children suffer more from diarrhea and other infectious disease, which impacts the nutrition in the manner like the children cannot absorb the nutrition and cannot retain the nutrient in their body. So this is a serious implication. We find that from our study, although 87% of the household have access to improved functional water sources within 150 meters from their home, coverage is not adequate. Like there is huge regional disparity, like 20% of the household in Borishal, Khulna and Sylhet do not have access to safe drinking water. Almost 1/10 of the household do not have continuous water supply throughout the year. And almost 2/3 of the household use less than 20 liters of water per day. And similar to that, at the national level, although 80% of the household use an improved latrine, like 35 to 38% of the household in Rajshahi, Rangpur and Sylhet division still do not have access to the improved latrine. And almost 11% of the household have access to clean, round-year usable latrine, like 90% do not have round-the-year clean latrine. Majority of the household share latrine with 3 other households, which might be a reason for not having a clean latrine. Approximately 25% of the rural household with children under 5 do not have a hand washing facilities close to the latrine. Similar to sanitation and safe water, at the national level, only 54% of the caregivers are found to be knowledgeable about the way of hand washing. Approximately 40% of the household having hand wash facilities are not aware of hand washing before preparing food or before serving the food. Same as the nutrition, the early childbearing, which is often related to early marriage, also exacerbates an intergenerational cycle of undernutrition. The child marriage scenario is improving in Bangladesh, no doubt, but still around 35% of the women in the age group 20 to 24 were married before reaching their 18, whereas 48% in the 30 to 34 were married before age 18. So among the women in the fertility range, 12% have given birth by age 15 and 48% have given birth before reaching age 18 and 70% have given birth by age 20. So what is the problem if they give birth early? The problem is if the adolescent girls are married early, their health and cognitive development is retarded. The small mother, the small place for intrauterine growth, which actually affect the nutrition and which is related with the preterm delivery. And that is the cycle how this is related to with the child malnutrition. Next is the situation in the urban slum. We all talk about the rural areas, we all talk about the urban areas, but we don't see much study on the urban slums. So urban slum is a distinct factor. The access to land for growing food is almost zero, so there is no land to grow food. Intergenerational support is also poor. There is unhygienic living condition and lower public services, which together translate into poorer nutrition and health outcome. Urban slums remain behind other urban areas in terms of indicators like stunting at birth, women empowerment, caring practices, infant feeding, and health environment. The Bangladesh Urban Health Survey 2013 reveals that 50% of the slum children below 5 years were stunted compared to 33% in non-slum areas. There is a huge gap. More than 1 in 5 women aged 15 to 19 in slum areas reported having ever been pregnant. And 25% of adolescent girls are of short stature, while 41% are underweight. And interestingly, the social protection coverage are mostly focused on the rural areas. The percentage in the urban areas is really low. The 2013 estimate is 9% only. So now intervention is required. Since the market cannot operate efficiently, there is market failure, the government intervention is required, which can come in the form of the social security program. Although the country spends like 16% of its budget on over 120 safety net programs, the proportion of programs aiming to improve maternal and child nutrition is still really small. So there is a revitalizing the whole system, the National Social Security Strategy. There is an option that all the food-based program can be translated into cash program. But the problem is the food program is important because food-based program play a critical role during several times during the emergency, like food price hike, flood, cyclone, in those time of the natural disaster. So if the child is in the first 2 years time, if there is a natural disaster, they are more susceptible to be affected. So at those point of time, the role of the social security food is very important. So at this time, the design and implementation of nutrition-focused social transfer program will be a major challenge, because if the program targets the food security, that will not be adequate, because food security doesn't ensure reducing the nutrition problem like the stunting rate. The conditional cash transfer program probably will not work much better, because in several countries, different studies show that conditional cash transfer is better than the cash transfer. Feasibility of effective intervention, such as bundling the cash transfer with the behavior communication change, can be more effective. For example, in one recent study shows that when both transfer and behavior change communication component were bundled together, the impact on nutritious food consumed by the household was larger. So there are other issues like the climate change, the impact of the climate change on the vulnerable people, including the children and women. That's also a very important point, but I'm not elaborating into that. And that was the critical point. I find from a review, this is not comprehensive. There are experts here who can touch more on this. Thank you.
Thank you, Dr. Mainul. I think it was a quite comprehensive presentation on the nutrition situation for mothers and children. You have touched on how the country is lagging behind in terms of nutritional status indicators, as well as you have also sort of touched on issues like the issue of the knowledge, the access, the coverage, the practice, and so on and so forth. So thank you for this. This reminded me of a situation which is happening in our neighbor Nepal. Many of us don't really know that Nepal is another country which is doing so well. We always talk about Bangladesh is doing very well in many sectors, but Nepal is also not lagging behind. And if we think of stunting, over the last 15 years, and the starting rate in Nepal has actually been reduced from 57.8% to 27%. So that was a huge improvement in Nepal, and how it has been done. I mean, there has been a large number of studies on Nepal which showed that apart from nutrition-sensitive programs, nutrition-specific programs, there has been huge improvement also in the way the nutrition is affected, the nutrition-sensitive programs, such as, for example, the use of toilet. I mean, Mainul has mentioned about the improvement that is happening in this country on wash. So similarly, Nepal has been going through all these. So we have another example very close to us, which has been very successful in tackling some of these. We now sort of turn to our panelists, and we have three panelists today, and we start with Dr. Mahfuza Rifat. Mahfuza is the program head in BRAC, and she's a medical doctor, and also she has a PhD University of New South Wales. Newcastle, University of Newcastle. Yes.
Thank you, Mushtaque Bhai, and thank you, the BIDS, to letting me to share my share our views from BRAC. First, I would like to thank Mainul Bhai for this presentation that was quite detailed, and it gives some the current status and the overview of the nutrition in Bangladesh. And I would like to actually share some of our BRAC's approach and some of the program highlights today. I'm mainly focusing on the nutrition. So our nutrition program in BRAC is quite, it is a long history. We started long back in 1975. But today I'd like to share one of the very big and challenging nutrition projects we worked with under the 11 Tribe project, where BRAC was the major implementer at the community level. So in that program, actually, we had some learning, providing nutrition program in a very intensive way, and that learning actually we took to our other programs, and currently we are actually providing nutrition services in 141 sub-districts of Bangladesh, covering 33 million. That is mainly nutrition intensive, but beyond that, from BRAC's health nutrition, that is we call essential healthcare package platform, we are also providing nutrition services. So our approach and our strategy actually based on the national and international strategy. So we followed by those recommendations. That 11 Tribe project actually started in 2009 in 50 upazilas, 50 sub-districts of Bangladesh, and then the main thing was we tried to use that 1,000 days, that windows of opportunity, and mainly focus on the IYCF practices. So we tried to provide intensive interpersonal communication and counseling to the mothers of the child and the caregivers. And at the same time, we had the mass media coverage as well as the stakeholders' involvement. So that is a kind of very intensive programs, and the visits and the frequencies of these counselings were very good at that time. And in the end, we actually found very good results in terms of the implementations. For example, we found that the IYCF indicators showed very good results in terms of the exclusive breastfeeding, the early initiation of breastfeeding, complementary feeding, and also the other the minimum acceptable diets and the food diversities. These indicators showed very good percentage from the baseline to the end line. The end line was done by a third party, and then the finding was really good. And that success we tried to take to our other programs. We scaled it up, and currently we are actually using that 11 Tribe platform for the childhood nutrition. And also for the maternal health, the 11 Tribe has a second phase called 11 Tribe 2, that's the maternal nutrition. It's a small project, though, but containing 10 sub-districts. So this is mainly focusing on the maternal nutrition, especially counseling the mothers, and also like providing the iron and folic acid supplements, and demonstration of the foods, about the diversity of the different types of foods. So that was done in the second phase of mainly focusing the maternal nutrition, and as well as the child one, the IOSCF one. So currently we are doing these two approaches in our different platforms of BRAC health programs. So, and the success showed actually that was a very good improvement from the baseline to the end line, and that's a significant improvement in these process level indicators. But we also had challenges. One of the challenges was in the stunting. At the end line, we found that the stunting actually, we reduced, there was a reduction in the stunting, but it was not only in the intervention area as well as in the non-intervention area we found that the stunting been reduced. So there was not significant difference of the interventions. So there might be some other factors that contributed to the reduction of the stunting, because the improvement of the economic development, the education of the mothers, and improvement in the water sanitation and hygiene. So that also gave us a view that nutrition cannot go alone. The other factors is also very important here. And so this is somewhat multi-sectoral approach we needed to tackle the nutrition. And so these learning actually we took back to our other programs as well. And then this is something actually also same with the anemia status. Like it didn't show much improvement in the anemia status significantly. So what actually needed here? So we found from the Mainul Bhai's presentation there are some other factors too, like for example the wash approaches, the water sanitation and hygiene approaches, that if the children is having their repeated diarrheal diseases, ARIs, and that also affects their nutritional status. It's not only that they are trained on the food and other things and that will improve. So that it needs a very much multi-sectoral collaboration. Also the other factors, other cross-cutting issues like women empowerment, education of the mothers, we already talked about this, and so this contributes quite a lot. We have seen the presentation about the early marriage and other factors. So how we can tackle all these factors along with the nutrition, that's a challenge for us, and thus now we are trying to do in a multi-sectoral way and providing the nutrition services to multi-sectoral platform, although this is not that easy. So currently we are working actually with government, kind of like the government is providing now the technical support and the strategic direction to us, and we follow the strategy and other things. And at the field level, we also try to involve the government workers in their stakeholders meetings and other programs. The other thing is we also using the community clinic platforms. So how we can, and we are trying to use our these community clinics and mobilizing the mothers and the children, the health, to take services from the community clinics. And we are also using the government-approved IC materials in the programs. So this is how, in a collaborative way, we are trying to provide health services. So and also the maternal nutrition project from the 11th trial phase 2, we found the tremendous success in terms of mothers are using iron folic acid, completing their doses, and also gaining a substantial weight gradually throughout the pregnancy. And these, at some extent, these results are beyond even the national average in our BRAC supported areas. But what we felt also at the same time, we need intensive nutritional programs and sustain these activities and interventions for quite a long period, so that we can see the longer outcome and outcome related other indicators. So what we need is actually prioritizing nutritional agenda, and also the commitments, the political commitments to take the commitments to actions related to maternal and child nutrition. And also we need a budgetary resource, the sufficient resource to do these services. So that was all from my side, and thank you all for patience hearing.
Thank you, Rifat. Rifat has very clearly sort of presented some of the work BRAC does, particularly the Alive and Thrive program. This program is quite high profile in the sense that organizations like the IFPRI, the International Institute, they evaluated this program. They were saying that the program has really shown changing behaviors, changing. We also wanted to challenge what they now. That one is, which is that although we are seeing very good results in terms of improved practices, but it is not showing up in the rates of what's going on. There are many hypotheses why it is the case. One is that the time period that we have is probably too short to see an impact on stunting. The second is that there might be a question about the mechanism of how stunting happens, for example, or how you reduce stunting, whether the kind of intervention that BRAC was doing is enough to reduce stunting. So these are kind of questions that are there, which we have to really understand. Mechanism through. We now move to Islam. Mr. Monirul Islam is the chief of the Economics Division of the Planning Commission, and we look forward to hearing his views, which is your government.
Thank you, Chair. Thanks to BIDS as well for inviting me in this very interesting and very challenging issue. One of the challenging issue of Bangladesh at this moment is the nutrition, no doubt at all. And I represent General Economics Division of the Planning Commission. As you know, we prepared the 5-year plan and the perspective plan of the government of Bangladesh. And we also did monitor the progress of MDGs in the last 15 years. And we published 8 publications on the progress of MDGs. And now we are in the era of SDG, and the co-responsibility for the reporting of SDG from our countries is also bestowed to us. And as you'll know that this year we are going to participate as a voluntary national review country, one of the voluntary national review country of Bangladesh of UN in the high-level political forum of United Nations. So in July this year, Bangladesh is going to participate there, and there are 7 goals will be discussed elaborately: SDG 1, SDG 2, SDG 3, that is poverty, hunger, health, and then 5, gender, 6, water, then 9, sustainable infrastructure, and then 14, life below water, and 17, the means of implementation. So particularly, I'm not like the Mr. Mainul, who candidly spoke that he was not an institutional expert, and me, it's also very true for me. But I had an experience working in the Ministry of Health and Family Welfare. While I was there, I worked under you when we were in the preparation process of National Health Policy Program, National Health Policy Preparation in 2007-8. You were in the committee at the time. I was the desk officer, sir. So the paper that is presented today is very critically analyze the existing scenario of Bangladesh with respect to nutrition, and it is all of the secondary data, no doubt. Just one simple correction with respect to when in the 3rd slide he mentioned that water and sanitation SDG 5, it should be SDG 6, not SDG 5. SDG 5 is gender. So a small correction here. And 2 information, when BBS and UNICEF 2016, and sometimes it is written 2015. What should be the correct reference period? Should be there, 2015 or 2016. It should be. Majority of the issues is the challenging part. Okay, the presentation that is shown, majority is the challenging part. This is the not availability, the stunting, wasting is this. But the way forward, what are the way forward for doing this is not actually presented here, I should say. Okay, let me say, it is true that if the way Bangladesh is changing, the way the Bangladesh economy is going, as you all know that Bangladesh's economy is changing from one trajectory to another. It is revealed in both the social and economic sectors of Bangladesh as well. For that reason, World Bank has categorically mentioned that some country did well in social sphere and some country did well in economic sphere, but rather Bangladesh belongs to a small group of countries who did well in both the spheres. Okay, and if we categorically see the progresses, particularly in the MDG region, because MDG was more pro-health, because MDG 4, 5, 6 was related to health, and one of the number one, that is education, poverty and hunger. The hunger is also part of the health, so 3.5 were health-related MDGs. But the success story of MDG shows that Bangladesh did well in reducing infant mortality rate and non-infant mortality rate, but interestingly, neonatal mortality rate is relatively higher. And neonatal mortality rate constitute around 70% of infant mortality rate of our country's context. So, and there is a close correlation between maternal mortality and neonatal mortality. And Bangladesh didn't achieve the new maternal mortality target of MDC. So in the base year, it was 574, and we have to reduce it in 143. But our latest status, WHO report says that the maternal mortality in 2015 is 176. And in the SDG, we have to come down to 70. Okay, so what I interesting to show you that it was globally decided that poverty might be the cause of nutrition, these sort of things in the MDG era. But in the SDG era, poverty is not, hunger is not part of, hunger was considered as the part of poverty in the MDG era. But in the SDG era, hunger is bifurcated from the poverty, and it is definitely given a single space in the goal area, and SDG 2 is hunger. And the challenging part, definitely, one of the success story of Bangladesh in the MDG era is that it could achieve the hunger part when it was measured in the under 5 underweight rate. In the 1990s, 66% under 5 children were underweight, and we were supposed to come it down to 33, and in 2014, BDS showed that it was 32.6. So Bangladesh could achieve the hunger target. But when we consider the stunting and wasting, definitely there is challenging. And the challenging part in the SDG era is that under 5 underweight is not the target figure of SDG. It is the stunting and wasting which is considered as the target indicator for SDG era. So definitely it would be a challenge, because the way in 1990s to 2015, the way we could reduce the under 5 underweight rate, we couldn't reduce the stunting and wasting, as was mentioned earlier. So definitely it is a challenging part, and definitely the way Bangladesh achieved the under 5 underweight, the same procedure or same strategy will not work for the stunting as well. Okay, this is the number one message, and we have to consider it. In the planning procedure, how you can say it, and it is categorically mentioned that yes, 7 5-year plan has categorically, as you can show that from our country's context, we also participate in the preparation of a sustainable development goal in the UN level. Bangladesh proposed 11 goals, and 10 of the 11 goals were aligned with the global goal. And there we also highlighted our priority issues, and definitely nutrition was there. And it is mentioned in the trigger paper that yes, in the 7 5-year plan, we have aligned majority of the issues of the nutrition issues very categorically. And in the 4th swap that is being just recently been approved by the Haque, also categorize the nutrition issues in the health issue. But nutrition is not a health issue as a whole. It is a multi-sectoral issues in our country's context. While we are in the process of preparing the SDG mapping, which ministry should do which one. That was the number one task of us after the SDG was approved. In the mapping exercise, one of the most critical area was the SDG 2, that is the hunger. You all know that availability, accessibility, and utilization, it should be the agriculture ministry who might be the lead for this goal. So there was the maximum number debate in our workshop were related to SDG 2. Who might be lead or who should be co-lead? Somebody says that it should be the responsibility of health. Health says it should be the responsibility of agriculture. Agriculture says it should be the responsibility of food. So lots of debates are going on. So by this, I want to mention that when there is interministerial coordination or cooperation is there, definitely that would be a challenging part. And with respect to nutrition, this is very crucial and very important issue to share with you that, yes, this is the challenging part. Because in the government, I'm sitting here and she is sitting there. I don't know what she is doing. So whenever one ministry and another ministry is responsible for the full implementation of nutritional issues or SDG 2, that would be definitely a challenging part. The success story is that, yes, the issue that has been mentioned and the challenging part is also mentioned in the fourth SWAP and also in the SDG document. And Bangladesh also have approved a national nutrition policy in 2015 that has categorically mentioned how to address the nutritional issues. I think in the trigger paper it might have come that what we are going to do with respect to nutrition. So I think that might be an issue. And another issue that the data availability. Yes, stunting and wasting, we have availability of data. But in the SDG 2, if we categorically consider the undernourishment, 2.1.1 indicator. In the government level, we don't have any data for undernourishment. It is only available in the FAO stat, about FAO stat. And also prevalence of moderate or severe food insecurity based on food insecurity equivalence index, FIES. That data is also not available in the government procedure. We have to wait for the FAO how they estimate it, and we have to collect data from them. But in the government procedure, there is no process for monitoring 2.1.1 and 2.1.2 indicator of the SDGs. Since I am telling about more on SDG issue because SDG has categorically captured nutrition in the SDG 2, and if we can in true sense implement fully, the challenging part of SDG is that the coordination, because it's categorically mentioned. You see that in SDG 3, that is health, but all the health issues has been covered, and it has also incorporated water and sanitation, that is SDG 6. It has also incorporated the environmental issue, that is SDG 13. It has also categorically issues the awareness building, that is primary education. So in the health, the goal is one, but other intersectoral issue has been covered in the SDG. So SDG is more integrated goal, and if we can categorically implement the SDGs, that will also help us in the implementation of the nutritional issues in our country's context. So at this moment, I'd like to thank you again for giving me a chance to tell something to you. Thank you.
Thank you, Monirul. You have touched on many different things, very important, all of them, including, for example, the issue of neonatal mortality. This is something which has been very resistant to change. And as many studies have shown, there has been reduction in almost all types of mortality except the neonatal mortality. He also mentioned about a very important issue, which is that if you really want to move forward in the SDG era, the business as usual won't really much work. We have been very successful in MDGs because we have been able to harvest the low-hanging fruits. Now, in order to move forward for the SDG, there will be higher-hanging fruits, things like health systems and so on. And so. So we have to really think about new ways of doing things, and for pointing those out. Now, finally, we have Dr. Fahmida Tofail. Fahmida is one of the very few people who understand ECD, the early childhood development. She works for ICDDRB, and we will be
Thank you, Mr. Fahid, for giving me the. I'm also thanking the BID for giving the opportunity to participate in this critical conversation. So I will talk. I will discuss from a different point, from different angle. As Mushtaque Bhai has already mentioned, that I am my expertise is with child development and linking all the factors that affect child development. So I'll try to link these two things: nutrition, child development, and the development. And the productivity. So first question, I'm thanking to Mainul for giving a very comprehensive presentation that is touching all the factors. Most of the factors that is linked with maternal and child nutrition. So there are few more factors that has not been addressed. I will try, from my point of view, I'll try to address those as well. So my first point is that I agree with my previous presenters. They have mentioned that nutrition is multifactorial and cross-cutting. So only like food supply and just reducing food insecurity may not improve the overall situation. So there are many other factors that has not been, some of those we have addressed, some are still, we haven't addressed, or like we didn't take any action. So